Well, good evening and welcome to this month's Ask Your Herb Doctor December 15th, 2023 edition. My name's Andrew Murray.
My name's Sarah Johannesson Murray. Good evening and welcome.
So you're listening to Ask Your Herb Doctor, KMUD Garberville 91.1 FM and on the web at www.kmud.org. We're also live streaming this program to our Western Botanical Medicine YouTube channel, so you can listen live right now on our channel by searching Western Botanical Medicine in the search bar on YouTube and clicking on the live stream. So tonight's radio show is the beginning of what will be probably a small series of 1, 2 or maybe 3 shows surrounding the gut and its microbiome and function. We're going to discuss the differing etiologies of the individual pathologies frequently associated with it. So lots of kind of new stuff, some technical stuff, and fast evolving science surrounding what we're going to discuss here. So my name's Andrew Murray.
My name's Sarah Johannesson Murray.
We're both licensed medical herbalists who consult with clients with a wide range of conditions. Our website is westernbotanicalmedicine.com. You can visit our site to see a list of our organic medicinal herb tinctures, and our contact details are there also. Alternatively, we can be reached on our toll-free number 1-888-WBM-HERB. Our Western Botanical Medicine Twitter's account handle is at Twitter account handle is
X
at
account.
WBM-HERB. So at WBM-HERB. And our YouTube channel is Western Botanical Medicine. Both links to the Twitter and YouTube channel are also on our website. Okay, so let's get into the topic for tonight. So let's just discuss a few terms first. I'm going to broadly outline, the processes involved in digestion, and again, this kind of adage, you are what you eat, kind of keeps coming back time and time again. In many different ways, you become what you eat, etc. So the digestive tract is an extremely important system, and our health is very much largely down to our functioning digestive system. It's how we assimilate all of the nutrients that we put into our mouths, and those nutrients are used in the machinery that drives our energy production and keeps us as organisms healthy and balanced, etc. And people probably don't even think too much about the derangements that happen in the gastro-intestinal tract that themselves have all the repercussions and knock-on effects system-wide as a result of that derangement. So we normally think about typical illnesses, but these are not necessarily illnesses of the digestive system, but which actually, by looking at it in a kind of counterintuitive way, you work it backwards and you can actually see the digestive system in its own right is the seat of health, because if you're not absorbing nutrients properly, or you have inflammation in your digestive tract, how do you expect any of the things that you eat and drink and consume to be correctly absorbed in order to provide the fuel for the rest of the machinery that needs to function? So some of the terms that we come across, and specifically with reference to tonight's discussion of the gut microbiome, with reference specifically to SIBO, small intestinal bacterial overgrowth. Let's just talk about some of the terms first that you may or may not have heard of. So SIBO, capital S-I-B-O, stands for small intestinal bacterial overgrowth. The small intestine typically, and I know Dr. Pete had mentioned this many times, but I know there are small numbers of thousands per gram of aspirate from the small intestine that are given as normal. But he would always say the small intestine is essentially sterile. In comparisons to the colon's bacterial count of 10 to the 12 or 10 to the 14 organisms per gram, that 10 to the 1, 10 to the 2, it is pretty sterile comparatively. So as I said, then the small intestine is typically sterile, but now I understand this is a relative and not an absolute term. And this owing to the environmental factors making it quite inhospitable, from stomach acids to the presence of bile, proteolytic digestive enzymes, to the intact ileocecal valve, which functions to prevent retrograde flow of colon contents back into the small intestine. And then you have the very own arm of the immune system, the secretory IgA. And lastly, the generally fast transit time associated with small intestinal motility, which maintains a steady forward motion towards the large intestine. So it's typically quoted as sterile, but very small numbers of bacteria there are not out of the ordinary. And in fact, just to make sure everyone is not going to fire this question back, well, actually, there's a lot of bacteria there, blah, blah, blah. Sometimes heavy bacterial colonization can also be isolated and inadvertently not forming a SIBO type pattern. So just the fact that SIBO is diagnosed by the presence of bacteria that shouldn't be there and specific species of bacteria which should not be there, and we'll get into the methane producing bacteria, the archaea, which is not even bacteria. Small numbers of bacteria can be quite normal, and even large numbers of bacteria do not necessarily predispose someone to SIBO. So it's kind of fluid, and I think that is the way life is. It's very fluid, and our bodies and us as organisms, where they have so many checks and balances, that a lot of things can be relatively deranged without actually causing pathology. And the body will always do everything it can to maintain fairly tight physiological control of pH or whatever you want to describe. But there are fairly large swings either way that can occur without any real negative effect. So that's SIBO. And then you have IMO, which is what they typically would call methane archaea overgrowth. So constipation, and we'll get into the kind of bowel type picture, but for methane dominant SIBO, which is called EMO, constipation is a very typical presenting finding for this type of overgrowth. Now, I mentioned the fact that these primarily due to methane producing or methanogenic microorganisms such as Methanobrevibacter smithii. It's been well characterized and well associated with this particular form of methane dominant methane producing bacteria, not archaea, not bacteria, found in the small intestine with patients who are confirmed as being methane dominant SIBO sufferers. So notably then, methane is produced mainly by archaea, the domain of microorganisms distinct from bacteria. Consequently, the word bacterial in the original name of this condition, methane SIBO, posed a kind of terminological conflict, which has been resolved by the introduction of a new term, intestinal methanogen overgrowth, or IMO, to express the diagnosis in patients with a positive methane breath test. And we'll get into breath testing, etc., later on, and show the distinction between the two, and then characterize the different protocols, obviously including herbs and motility agents that are used in the treatment of it. So you have SIBO and EMO, and then you have SIFO, S-I-F-O. So this is small intestinal fungal overgrowth. It's characterized by the presence of excessive numbers of fungal organisms in the small intestine associated with gastrointestinal symptoms. Candidiasis is known to cause GI symptoms, particularly in immunocompromised patients or those receiving steroids or antibiotics in certain instances. And this is prolonged and protracted antibiotic use. Now, however, only recently there is emerging literature that an overgrowth of fungus in the small intestine of non-immunocompromised subjects may cause unexplained GI symptoms. The most common symptoms observed in these patients were belching, bloating, indigestion, nausea, diarrhea, and gas production. The underlying mechanisms that predisposes to SIFO is unclear at this point, but small intestinal dysmotility and use of proton pump inhibitors has been implicated. Now, these are directly lowering stomach acid, and as we'll see, pH is one of the safeguard mechanisms to prevent bacterial overgrowth. I mean, obviously it's there for breaking down and cleaving the bonds between different food groups, but and by virtue of its acidity, it's also makes a very hostile environment for organisms. So then you have IBS, irritable bowel syndrome, or irritable bowel syndrome. It's one of the most commonly was going to say irritable bowel disease, or IBD and IBS are fairly kind of overlaid. So IBS is one of the most commonly diagnosed gastrointestinal diseases. Now, IBS, in the absence of any other causative disease, is defined as the presence of abdominal pain or discomfort with altered bowel habits. So motility, visceral sensation, brain-gut interaction, and psychosocial distress can all play a role in the development of IBS. And IBS can also be broken down into more specific diagnoses, which include IBS with diarrhea, known as IBS-D, and IBS with constipation, or IBS-C, and IBS with mixed bowel patterns, so IBS-M. So then you come on to the irritable bowel diseases. So these commonly grouped as Crohn's disease and ulcerative colitis. Okay, so Crohn's disease then, as a distinction between that and ulcerative colitis as one of the inflammatory bowel diseases, can affect any part of the GI tract from the mouth to the anus. So the whole GI tract can be affected by Crohn's. Now, most often it affects the portion of the small intestine before the large intestine and colon, and damaged areas appear in patches that are next to healthy areas of healthy tissue, and inflammation may reach through the multiple layers of the wall of the GI tract. Whereas ulcerative colitis occurs in the large intestine, the colon, and the rectum, and pretty much confined to those areas. Now, damaged areas are continuous, not patchy. They're usually starting at the rectum and spreading further into the colon, and inflammation is present only in the innermost layer of the lining of the colon. So those are the two main inflammatory bowel diseases, and funnily enough, during our 4 years studying herbal medicine in the clinic in year 3 and 4, we saw quite a lot of patients with Crohn's disease and ulcerative colitis, and these people had bloody diarrhea and really severe cramps and malnutrition, deficiencies of different vitamins. There was skin. It affected the skin and collagen formation, etc., etc. I haven't really seen too much or heard too much of it here, but maybe there's some connection in England with some diet or maybe lack of sunlight, because I know vitamin D plays a large part in preventing this. So now digestive activity begins with the sight, sounds and smell of food. Just looking at or smelling appetizing food can result in the brain sending signals to the salivary glands to make the mouth water and the stomach to promote gastric secretions. And then chewing essentially mixes the food with saliva from the salivary gland, and then various components from the salivary glands like amylase in the saliva chemically digest the starch in the food, and it's all chewed up and lubricated by mucin, which is also secreted. This is a slippery protein in saliva. And then each mouthful should take, I remember the adage, you should chew your food for 60 seconds, so a minute a mouthful, and basically reduce it to a complete slurry, but people, I think, probably chew quicker than that. So this basically mixes the food together, and the food is formed into a small ball, and that's pushed into the back of the mouth by the tongue, and then involuntary muscular contractions in the pharynx then produce the bolus down towards the esophagus. And this swallowing reflex takes a couple of seconds. So that from there on in, from the moment you swallow, it's a fairly autonomic process of muscle contraction that you don't really have too much influence over. It's kind of autonomic. So basically then in the esophagus, the bolus is moved along by these rhythmic contractions of the muscles. And then for medium-sized kind of boluses, it takes about 5 to 8 seconds perhaps to reach the stomach. And then foods mixed with the gastric juices, strong muscular contractions in the stomach will reduce the food to what they call a chyme, a C-H-Y-M-E. It's kind of a milky, thick, milky material, basically a slurry. And then the pyloric sphincter at the lower end of the stomach slowly releases this chyme once it's been all broken down by the acids and the enzymes into the duodenum. Emptying the stomach takes between 2 to 6 hours. It takes 3 to 5 hours from entry to the duodenum to exit from the ileum. The small intestines structure of folds, these villi and microvilli that we'll get into, increase the absorptive surface area and allow maximum exposure to enzymes and complete absorption of the end products of digestion. So most of our digestion and the process of assimilation and absorption happens by the microvilli and the villi in the small intestines.
And that's what gets so damaged in celiac disease. And just as a little side note about gluten sensitivity, the transglutaminase that gets activated under the influence of undigested gluten will cause some degree of damage to those little villi, no matter whether you're actually full-blown celiacs or not. Just any amount of specific allergenic proteins like the gluten protein, undigested or unfermented, I should say, will cause destruction and damage to that by varying degrees. And so will a lot of other food additives. I know we've done shows in the past about different food additives and how they damage that and cause a cross-linking of the protein in the intestines to damage the little hair-like structures that increase the absorption of all of our essential nutrients.
So millions of these tiny finger-like structures called villi then project inwards from the lining of the small intestine, and this large surface area they present allows for rapid absorption of digestive products. So then small amounts of this chyme are ejected approximately every 20 seconds from the stomach into the duodenum. The chyme is mixed with secretions from the pancreas and the gallbladder. These fluids contain bicarbonate, enzymes and bile salts essential to the digestion process. And then peristaltic waves of muscular contraction mix and move the chyme down the duodenum and into the jejunum. It has a huge surface area created again by finger-like structures called villi, and these assist with the absorption of the end products. By the time the chyme has reached the ileum, most of the digestion processes involving carbohydrate, protein and fats have occurred. Its main function is to absorb the end products of digestion and release hormones that regulate feelings of fullness. Undigested remains of food are passed through a one-way muscular valve into the first part of the large intestine known as the cecum, a small pouch that acts as a temporary storage site. By the time food remains have reached this point, about 5 to 12 hours or thereabouts have elapsed, the large intestine is 1.5 to 1.8 meters in length, and it's divided into the cecum, colon, and rectum. And the colon's further divided into 4 parts: the ascending colon, transverse colon, descending colon, and sigmoid colon. So the large intestine consists of, as said, the cecum, colon, rectum, and anal canal. It's about 1.5 meters long and has an average diameter of about 6 centimeters. Now, the 4 major functions of the large intestine are recovery of water and electrolytes, formation and storage of feces, and fermentation of some of the indigestible food matter by bacteria. Slower peristaltic movements push undigested food remains along the colon, which mix freely with the resident bacterial population. The bacteria ferment some of the food remains, producing short-chain fatty acids as well as other important chemicals such as vitamin K. The liquid from the small intestine changes into a semi-solid known as stool, and the sigmoid colon temporarily stores the stool until a mass movement empties it into the rectum. Residence time in the colon ranges from 4 to 72 hours, a large spread there, with a normal average of 36 hours.
Yeah, but that might be the normal average, but that's not necessarily the normal healthy length of time for transit.
Yeah, 16 hours or so would be pretty good, wouldn't it? The rectum's external opening, the anus, is controlled by a set of muscles. When filled by a mass moved from the sigmoid colon, the rectum stretched and produces a desire to defecate. If inhibited, the urge to defecate subsides but returns several hours later. And you should never put it off. Okay, so you're listening to Ask Your Herb, Dr. KMD Garberville, 91.1 FM from 7:30 till the end of the show. You invite to call in. This month's show is about GI disease, and we're going to start with small intestinal bacterial overgrowth and go through the physiology of this and describe the symptoms, and then also get into the treatment of it and the medicinal herb approach to it. So, when the protective barriers preventing bacterial overgrowth in the small intestine fail, SIBO occurs then. Gastric acids and bile destroy and prevent bacteria from passing through the intestines after ingesting food. So SIBO is usually associated with achlorhydria, and I want to just bring out these things as we go through some of this physiology to describe these things, so that if people have understood in their own blood work, they see things like low B12 constantly coming up, even though it doesn't seem to be any real symptom. Or if they know that they're on proton pump inhibitors, for example, or omeprazole, they've got gastric ulcers or duodenal ulcers where, doctors are controlling their acid production to try and heal their ulcer, that this very acid reduction can be causative for small intestinal bacterial overgrowth, because the stomach acid is one of those things that keeps these things in check. It's not just for digesting substances.
And if we go back even to a more basic metabolic function, if you're low thyroid, even by a little bit, then your digestive juices will be diminished, and especially your hydrochloric acid from your stomach. And if you're not digesting your food in your stomach properly, your stomach will empty into your small intestine undigested food that can feed bacteria. And I think a lot of
at a higher pH too.
Well, yeah, if the stomach's not producing a lot of hydrochloric acid, you'll have a higher pH, which means there's less acid.
Okay, so as Sarah was saying, then low thyroid function predisposes to achlorhydria, which is the term used to describe low stomach pH. And this self-sustaining cycle of dysfunction in the metabolic energy production has ramifications within the digestive tract and all the negative energetic sequelae that follow.
And the other thing, too, to mention is that we know the average temperature is 98.6, or healthy temperature, right? We've known that. We've been told that. But they're now trying to lower that temperature because so many people are low thyroid and have a decreased metabolic rate, and their bodies are colder, and they're trying to say that a normal temperature is closer to 98 instead of 98.6. So if that's not reason enough to cause undigested food and improper nutrient absorption, I don't know what is. And besides, Dr. Pete would always say, if your temperature is below 98, then your immune system's only on about 50% power.
Okay. So the other thing that, trying to get into the concept of, what were you going to say?
Well, so if your immune system's only functioning at half its strength, that means then it can't deal with all this undigested food and allergens that could be getting transmitted and passed into the intestines, where it shouldn't be. It should be digested in the stomach first. Okay,
so we talked about low stomach acid, which can be due to proton pump inhibitors, omeprazole, or other acid regulating modalities for treating peptic ulcer or duodenal ulcer, and also low thyroid, which can predispose to achlorhydria. So proteolytic enzymes digest and degrade bacteria in the intestines. So chronic pancreatic insufficiency is also associated with SIBO. Migrating motor complexes, a term, is responsible for peristalsis and cleaning of the small intestine and prevents retrograde translocation of bacteria. So SIBO is associated with disorders of abnormal gastrointestinal motility, such as irritable bowel syndrome, narcotic use, post-radiation enteropathy, diabetes mellitus, scleroderma, and hypothyroidism, as mentioned. An intact ileocecal valve and antegrade motility of the ileum prevent retrograde translocation of colonic bacteria in reverse back towards the small intestine. So this is a structural anomaly. Now, some anatomic abnormalities lead to stasis of the bowels, which may predispose them to SIBO. Such anatomic disorders may include small intestinal diverticuloses, bowel strictures, post-operative adhesions, gastric bypasses with blind intestinal loops formed, and ileocecal resection. All of these will be very negative and impacting on the GI tract and will certainly predispose a patient to SIBO. Lastly, the gastrointestinal tract secretory immunoglobulin IgA abundance prevents bacterial proliferation and maintains intestinal immunity. So immunodeficiency disorders such as acquired immune deficiency syndrome or combined variable immunodeficiency and IgA deficiency are also associated with an increased risk of SIBO for this reason. So the actual prevalence of small intestinal bacterial overgrowth is truly unknown. Irritable bowel syndrome, intestinal motility disorders, and chronic pancreatitis are the most predominant cause of SIBO and account for 80 to 90% of cases. And SIBO is more prevalent in the female population and elderly individuals. The incidence of SIBO increases with age, secondary to hypochlorhydria, as we've mentioned, low stomach acid, and intestinal dysmotility. In many cases, more than one cause of SIBO can be identified. Do we have a caller on there? Okay, yeah. So just to say again, the number here, if you're anywhere in the world, 707
923 3911.
Okay, so let's take this first caller. Caller, you're on the air. Where are you from, and what's your question?
I'm from Layton, Kentucky, which some people call Laytonville.
Layton, okay.
I was going to say, you mean Long Valley?
Yes, I want to thank you so much for the program. I'm a 61-year-old adult male with a hyperthyroid, and hyperthyroidism is mostly incurred by women. And I made the mistake of following an AMA regimen without and being misdiagnosed for almost a 2-year period until I sought out the assistance of an endocrinologist, found a proper diagnosis. That being said, at this point in my life, and again, this program's been very helpful. I'm listening to the science. I'm going to go back to the archive and listen to it again. I'm wondering, as an adult male at 61 with a hyperthyroid and with an issue that's been confounding me, I'm a chef. I have a really wonderful diet regimen, and I'm mindful about what I eat. But I've been experiencing some issues with my butt. You know, I mean, let's put it out there. It has to go out. But I have leaching. I have an issue, and it's discomforting to me. It's societally embarrassing. But I'm going to be honest about it because so my question is, what can I do dietetically to remedy, or with plant medicines perhaps, or yogurt, or whatever invigoration of my gastrointestinal system? Because I know that eating is it's not just nutrition. As a chef, I'm feeding my whole biome here. Okay, help me out here. I'm really enjoying the program.
Sure.
And thank you for letting me reveal myself in this situation, because it's discomforting.
Absolutely.
I'm going to take the answer off the air, and thank you so much.
Before you go, sir, can I just ask you, have you had any treatment for your hyperthyroidism before you go off the air?
I use black walnut tincture.
Okay.
Which I self-prepare, and I've not. I won't have surgeries to screw with my body. I won't devote myself to thyroid cleaning. I have friends who had surgery during the thyroid and thyroids, and they're in danger. As soon as the pharmacy shuts them down, their time is limited. I mean, I'm not certain that folks understand that, you know, I'm an American with a disability. It's from the pineal gland all the way to my reproductive organs, my heart, my kidneys, my liver. Everything is under pressure from this disease. And that it affects me contextually, mentally. So, yes, I see Reiki therapists. I receive acupuncture. I meditate. And I self-monitor. I am aware of seasonal changes. If the skin gets thick on the back of the foot, it's a signature. You know, my hair grows way fast. I'm aware of the signals.
Okay, great. Well, I'd love to offer some information on what kind of tests you could do, because a lot of cases of hyperthyroidism are actually people who have too much T4, which is termed hyperthyroidism.
Yeah, I know.
But T4 is completely inactive, and it does not occupy the thyroid receptors and cause an increased metabolic rate. It has to be converted to T3. So a lot of times people who are diagnosed with hyperthyroidism, which is too much thyroid, a lot of times it's just...
I have Graves as well as Hashimoto's.
Okay. So what can happen there then is that you're actually suffering from a lack of T3 in most cases. I'm not sure with you. I'd have to see your blood work, but a lack of T3, and there are a lot of different dietary recommendations for helping your liver convert the T4 to the T3. So
That's what I'm looking for.
Yeah, so you can get enough T3 to then lower the adrenaline, which is what too much T4 causes and gets mistakenly diagnosed as too much thyroid, but really it's too much T4, which is a thyroid hormone, yes, I know, but it's not active. It has to be converted. So there's a diet that we can send you out, a diet sheet, and Andrew will also talk to you about herbs. And yes, there's definitely something you can do to help reduce your adrenaline and or your T4. And, you know, we have also seen people with high T3 levels too, and then there are herbs that can address that. But most of the time, we see people that have high T4 levels and low T3 levels. So really, they're actually diagnosed with hyperthyroid, but they're really low thyroid because they don't have the active thyroid hormone. And therefore, their body has to compensate for energy with increasing adrenaline.
Okay.
Because they don't have enough T3 to give them energy. But Andrew can comment on a couple herbs that are helpful in lowering the T4.
Thank you so much.
And helping the conversion of T4 to T3.
Yeah, well, first of all, I wanted to say that I think what you've mentioned about the adrenaline is really the underlying cause here. So unless you have any kind of inflammatory bowel disorder that may predispose you to chronic diarrhea, which, yes, you know, I totally agree, it's difficult to manage and it's definitely embarrassing. And I've worked with people in the past, like in England, with ulcerative colitis, and it's uncontrollable and it's very much a problem just all day long and, you know, at night time too. So in the absence of any inflammatory bowel disease, which would predispose someone to chronic diarrhea, then adrenaline would be the next best finger to point at as causative, and so your thyroid situation may well be part and parcel of that. That's the first thing. I'd want to see what your labs look like and see in the context of what you're taking in terms of thyroid hormone, and possibly show that really you're running on too much adrenaline that's not being controlled properly by having adequate thyroid hormone, and that is what is going to cause your sympathetic stimulation and the inability to control bowel and everything just moving way too quickly. If you want, the best thing to do, and quite seriously, at the end of the show, my email address is andrew@westernbotanicalmedicine.com. Really, I think outside of the context of talking to you for the next 25 minutes, if you want to go ahead and email me, I'd be happy to consult with you. There's certainly different herbs that can be used, but again, are we looking at a kind of inflammatory bowel disease type pattern, or are we looking at a high adrenaline and a thyroid imbalance? So,
or both.
Yeah, or both. Who knows? Without getting too deep into it, but I would say if you just want to email me, andrew@westernbotanicalmedicine.com, I'll be happy to turn around some paperwork and we can go from there.
I will certainly do that, and I appreciate your thoughtfulness. Like many in the, I just shied away from the AMA ever since I was misdiagnosed, and like so many folks in this part of the world, healthcare is not only a financial issue, but it can be an issue of just being able to get the care that you're looking for.
Yeah.
So these programs like this speak to the greater vitality of Cayman and how we help each other. Yeah. So thank you for helping me and Andrew at Western Botanical Medicine. I'm going to send you my email address. And thank you for helping me address my own personal health issues.
Yeah, you're
And
welcome.
to each and every listener out there, may the best of health occur for each of you. I'm there for you if you need a hug.
Oh, thank you. And please support KMUD. If you like shows like this, please support our local radio station here.
Okay, so obviously anyone listening is so important. We're such a rural place here now. I know pledge drive is all done and whatever, but Kmart could always use more donations and more people to help join. Okay, we've got another caller, so let's take this next caller. Caller, you're on the air. Where are you from? What's your question?
Hi, I'm from the San Francisco Bay Area,
Hey.
and I have a couple questions regarding Dr. Mercola's defamatory statements surrounding Progesti, which
Go.
is the product that Dr. Pete created.
Okay.
And if anyone wants to get up to speed on those statements, just go to Danny Roddy's Telegram channel at t.me/Danny Roddy. But I first want to make a couple of points. You can really understand a person's character and their integrity in how they honor someone after their death. And I'm very disappointed in the influencers who are interviewing Mercola or being interviewed by Mercola, knowing that he is intentionally attacking Progesti, the very product that Dr. Pete invented, and Kenogen, the company that is supporting Dr. Pete's widow, Catherine. And I find it curious what Mercola's motives are, considering that according to a 2017 affidavit, Mercola's net worth is $100 million. So why defame a product from a small business like Progesti when you don't need the extra income? And why announce that you're formulating your own progesterone product when Progesti is the best product on the market? So Andrew and Sarah, I'm curious what your thoughts are on two claims that are damaging that Mercola is making. Number one, he's saying that Progesti is a bad product because there's no way to get the dosing accurate. And number two, he's claiming that the plastic is harmful.
Okay, well, I'll answer this question, Andrew. Number one, it is illegal in the United States to sell progesterone for oral use. Okay, that's number one. So I don't know if Mercola understands that or who understands that's selling a progesterone product. It is not legal if you want to sell it as a supplement or as a drug. It is not legal to prescribe, to recommend, to suggested dose use on the label for internal use. So I want to put that out there. That is the rules of the country that we live in here and now. Secondly, Progesti is sold in an LDPE bottle, and it is a low-density polyethylene. We've done a lot of research on different types of plastic, and polyethylene is one of the safest plastics there is. It's a food-grade plastic. We've tested our ethanol, the alcohol we use in our tinctures. It comes in HDPE, which is a high-density polyethylene barrel, and we've had the USDA lab in Berkeley, California, who test the food safety department in the USDA lab, test our alcohol for any residue of plastic, plasticizers, estrogenic compounds, and it came back perfectly clear. It was only pure ethanol, 95% pure ethanol, and 5% water. So not only do they say that polyethylene is the safest plastic, we've proven it, because if anything's going to extract an estrogenic plasticizer, BPA out of a plastic barrel, it's going to be ethanol, because ethanol is such a powerful solvent, or an oil. But we were, the ethanol comes as 95%. It's 190 proof ethanol alcohol, and it extracted nothing out of the HDPE. So number one, Kenogen manufactures Progesti. It's 90% vitamin E, 10% progesterone, and it's in an LDPE bottle, which is low density polyethylene. It is the safest plastic you can use. And if anyone's saying it has BPA or other estrogenic compounds like that, that's impossible, because polyethylene doesn't leach BPA. So that, just to set that straight. And then as far as dosing is concerned, if anyone's going to try to dose someone for oral use, that's not legal. If you want to recommend someone to take it topically, that's perfectly legal. But as far as what it contains, it's 10% progesterone, like I said. And it's very easy to figure out how many milligrams of progesterone you're getting in a teaspoon measure. A 16th of a teaspoon is 25 milligrams. An eighth of a teaspoon is 50 milligrams. It's that simple. It's clear, it's concise, it states that it's 10% progesterone. Anyone can figure out how much is in a dose with a teaspoon measure. And there you go. That's the truth of the matter.
Awesome. Thank you so much.
Thank you for your call.
Okay, well, that's the first I'd heard about any sliding in the background there or stabbing in the backs for the remaining wife, Dr. P. Keena Joan, and Progesti, and that's a real shame that Dr. McCullough's lowered himself to that level. Okay, anyway, so that's a bit of a side note here. A number of you in the area or out of the area want to call in and ask any questions about this month's discussion on SIBO. 707-923-3911. The lines are open from now until about 5 to the top of the hour. So to carry on then, even the presence of abundant bacterial species in the small intestine doesn't necessarily correlate with SIBO, as we mentioned, but the presence of endotoxin-producing invasive species does. Dr. Pete made a big mention about endotoxin, and we did lots of different shows on endotoxin and LPS production, etc. Now, bacteria can produce enzymes or endotoxins which damage the epithelial cell layer, resulting in SIBO symptoms of distension, bloating, belching, and gas production, as well as the very gas production that happens as a result of the bacteria which are not supposed to be there in the first place. So the most common species identified in SIBO are Escherichia coli, E. coli, Aeromonas species, Klebsiella species, and these anaerobes basically cause direct epithelial injury and produce enterotoxins, as we mentioned, where aerobes only produce enterotoxins, resulting in intestinal inflammation. So bacterial overgrowth can also affect bowel motility. And we'll stop it there and take this next caller. Caller, you're on the air. Where from? What's your question?
Hi, is that me?
Yeah, you're on the air. Where from? What's your question, ma'am?
I'm from Berkeley, and I'm hoping you'll talk about treatment for colitis. But also, I wonder, is it still possible to get Dr. Pete's newsletters?
Yes. You can email raypetepublishing@gmail.com, and you can order the newsletters, the back issues.
Okay, yeah, so far as colitis is concerned, go ahead.
And if you want to, if you don't want to have to remember that or write that down, we have it posted on our X Twitter. I can't get used to saying the link there to order the backordered newsletters, as well as I think there's a couple books that are still for sale.
And what's your X handle?
It's at WBM Herb.
Yeah.
WBM for Western Botanical Medicine, Herb, HERB.
Great, thanks.
Okay, thank you.
Okay, you're welcome. So far as colitis is concerned, that being an inflammation of the colon here, that would come into the last kind of categories of what we would cover. I know we're not even going to get to the end of, not even the beginning, middle of SIBO's discourse here, but hey, that's what next year's all about. So the fact that there's an inflammation, there's an inflammatory process, and so there's definitely anti-inflammatory strategies that would be useful. Obviously, dietary advice that would be useful. There's certainly a lot of herbs that would work as an anti-inflammatory and also for stress reduction. I know with ulcerative colitis and Crohn's, using herbs like valerian and simple kind of quote-unquote sedative type herbs had a fairly big impact on people, and probably because it's lowering adrenaline. And again, adrenaline is a big driver of inflammation. It's a disordered physiology that shouldn't really be happening unless you really need to get away from something. So anti-inflammatories and stress-reducing compounds would be part of a kind of colitis treatment, but I think also very much predicated on diet. If you ever want to, anybody who's listening, not just that lady who just called in, but anybody who's listening, if you want to just email me, Andrew at Western Botanical Medicine, about anything, please feel free. And if I've got it to my fingertips, I'll happily send you information regarding it. Okay, so In SIBO, then, the endoscopic or histopathological appearance of the mucus is usually healthy, so you don't normally see any real changes there. Non-endoscopic changes, non-specific endoscopic changes, rather, maybe things like edema, generalized edema, sometimes loss of vascularity, where you just don't see that kind of healthy pink coloration. There's more of a very pale, kind of quote-unquote anemic type picture there because of the lack of vascularity. What they call and describe as patchy erythema, again, so the patchy areas of patchy redness in amongst the kind of sea of pale, or rarely ulceration. And then other non-specific findings may include things like villus blunting. So where the villus are those little finger-like projections in their billions in the small intestine to increase the surface area, they may not have such a pronounced point. And typically, if you're looking at a hair-like structure, it ends in more of a point. But in villus blunting, those villi are kind of reduced back, as it were, towards the knuckle, if the villus was a finger, and you don't have such a pronounced fingertip, but more the middle of the joint where it's rounded. So villus blunting is sometimes visualizable. Okay, so we have another caller. Caller, you're on the air. Where are you from? What's your question?
I'm from the Humboldt Bay area. My question, a friend of mine said that, mentioned that beef, basically the cattle that are finished off at least on corn, maybe the pH of the meat, I don't know, maybe that's what that she said, that the pH is higher or something like that, or when you digest that beef, the pH is higher, less acidic, and maybe it's harder for your body, or maybe it's more acidic, actually.
Right.
And so some of the organisms that are in the meat can actually pass through your body and potentially cause some problems. So I just wondered if you know anything about that. And then secondly, if I'm not sure if you guys had past shows about the direct connection of your immune system with your digestive lining and system, and the impact that the chemicals that are associated with Roundup basically have on wiping out some of basically your sort of that thin protective barrier that is responsible for letting certain things pass through and other things not. Anyways, if you guys are going to cover that in the future, you don't have to go on about that. Just about the corn-fed beef versus like grass-fed. If you know anything about that, I'd appreciate it.
Right. Okay.
Thank you.
Yeah, thank you for your call. Did you want to say
Hi,
something?
yeah, well, yes, I do know that grass-fed beef have healthier stomachs that is a more neutral pH versus corn-fed, because all that corn causes an acidifying environment in their intestines. And I'm sure the meat from a grass-fed cow is going to be healthier because the animal is healthier. I mean, it's just natural for cows to eat grass, and corn, a little bit of corn for a cow that you're milking can help give it a little boost, but it needs to be primarily grazing, obviously. But I haven't actually, I'd have to do some research on whether the meat is less acidic. I do know that it's recommended when you eat meat, because it is acidic, to make sure to balance it with, number one, the anti-inflammatory protein that comes with most pieces of meat, and that's gelatin, naturally occurring around the bones and the joints, because meat is more inflammatory. The muscle part of the meat is more inflammatory. And number two, to balance that with lots of alkaline foods like dairy. And, dairy is actually more neutral, but also like greens. Sorry, Michael, were you wanting to say something?
Yeah, I had a question, kind of what you were, I hear people talking about A1 versus A2 protein in milk. What do you know about that, and does it really make a big difference?
Well, I think some people, I've definitely heard clients say they have an easier time digesting Jersey milk, which is the A1, rather than like the Holstein cows. Personally, I prefer the flavor of the Holstein cow milk.
I think you might have that backwards. I think the Jerseys are A2. The A2 is the more.
Oh, sorry.
rarer.
Yeah, sorry. I mean
not the usual one.
Right. Yeah, the usual one is the Holstein. The more rare, the ones they don't necessarily use for dairy, they use it more, for milk, they use it more for cheese and butter is the Jersey because they have the less inflammatory proteins. But I think you have to be sensitive to that. I think you have to have a sensitivity because I have known people who say they can drink Jersey milk and they can't drink Holstein. And there is a whole science behind it. And
then my understanding is like goat and sheep and stuff are the A2 protein or
they're just a much smaller protein. And, Holsteins can get up to 4 to 5 gallons a day. That's how much milk you can get from them a day. Jersey produce less, but goats and sheep, obviously much less. But it's a smaller protein structure, and it is more similar to human milk protein, the goat and the sheep. So a lot of people feel healthier with that versus cow.
Okay, so that last caller, then definitely the whole concept of the potential renal acid load, the PRAL of a substance, is down to its protein content, and obviously those meats in general have a relatively high PRAL. So whether or not an animal being fed corn versus a grass-fed animal, whether or not it would really have that much difference to its physiology, and it would have to be down to the protein content of the meat, because the protein content itself would be responsible for producing those amines, and that would be, the acidifying side of it.
But the other part about the acidifying side or the inflammatory side is that aged meat is more inflammatory than fresh meat, and fresh meat will have more glycogen stores in it, and it actually tastes sweeter. And we've done these experiments ourselves where you age it 1 day, you age it 5 days, and what's the difference in the taste of the meat? And Dr. Pete was always concerned about making sure to not age your meat, even if it does make it more tender. It's actually a process of breakdown of the protein that tenderizes the meat, but those breakdown proteins are cadaverine and putrescine, and they are inflammatory, and in a sense your meat is starting to rot, and that's what is tenderizing it. So it's always best to have your meat as fresh as possible, and that will be less inflammatory too. And yes, Michael was right. The A2 milk comes from the Jersey and the Guernseys, and the A1 protein, it's the type of casein. The A1 protein is coming from the Holstein varieties of cows.
All right, so it is 7:53 here. I don't think there's probably any time for any other callers, but we'll just kind of wrap up things here. And obviously next month we will pick up where we left off. We haven't even got into any herbs at this point in time, so I think I just want to quickly put it out there here in the context of both inflammatory bowel disease, but specifically for SIBO or EMO. The main things that we have found out and research has borne out. Number one, the whole concept of intestinal motility. That is something, again, as a predisposing factor to SIBO. Having a very slow motility will predispose somebody more to SIBO than having a fairly rapid transit time. So using things that stimulate the digestion, so things like gentian, Gentiana lutea, the European gentian, things like alpinia. Alpinia is in the same family as ginger and the Zingiberaceae. It's not quite as hot as regular Zingiber officinalis, but alpinia, I make a very nice syrup of it. It's a very, very nice warming aromatic. So both alpinia and gentian are used prior to food to stimulate the stomach, to produce stomach acid, to get the pH of the acid down so it's concentrated, and so therefore it's going to have the best possible chance of breaking food down. And gentian again is a stimulant for the digestive tract, so it pumps all these enzymes out of the pancreas. It gets the bile to be emptied into the intestine, or from the bladder, gallbladder, where it's a concentrated form. It basically, the cholagogue stimulates the liver, stimulates the gallbladder to contract. So these things prepare for food. And then things like berberis, berberine, well-known, a kind of quote-unquote antibiotic specifically for SIBO.
Well, golden seal is not only bitter, so it will stimulate your digestive juices, your salivary enzymes, and your liver the bile flow, but it also contains a lot of berberine, which is a compound that is effective against some of these small intestinal bacteria that can cause the SIBO, the small intestinal bacterial overgrowth. So it's kind of like a one-shot wonder.
Okay, so let's just relax and wrap up the show here so we get everything done in a good, timely fashion. It is the last show this month, so next month...
The last show this year.
Last show this year. So next year, 2024, we will be carrying on with our discourse about SIBO and the physiology and the treatment of SIBO and the breath testing and the diagnosis, what it means, and the amount of hydrogen, the amount of methane that you would see on a test, what that would disclose, and the whole rationale about treating it. And then we would move on to distinguish the methane-producing archaea from the hydrogen SIBO, and then look at inflammatory bowel diseases as another broader kind of category of inflammatory bowel disease. Okay, so the number, if you want to reach anytime after Monday through Friday, is 1-888-WBM-HERB. My name's Andrew Mai.
My name's Sarah Johannesson Murray. Thanks for tuning in and listening tonight.
Yeah, we can both be reached Monday through Friday, and our email address, etc., is on our website, westernbotanicalmedicine.com. And just wish you all out there a very happy Christmas and awesome New Year. Don't be afraid, just don't be afraid. And we'll see you in January. Have a happy Christmas.
Merry Christmas. Thanks for joining us tonight.
And Christina, you should call back.